operations and sort of set the benchmark for performance. Before we get into the data, though, I'd like to just sort of remind people or talk about the fact that benchmarking is a pretty well accepted sort of business technique, right? It's always good to be able to compare yourself and your performance, specifically, though, against your peers. One of the reasons we started this whole survey about 11 or 12 years ago was that many of us sort of got tired of being compared to the generic emergency department, which in no way represented the academic operations. And so we started this survey specifically to look at academic emergency medicine so we could compare ourselves against our peers. And so we've been pretty successful, I think, at building a very good database that allows us to compare yourself against very specific compare groups. So now you can use that data not only for comparison, but to plan your future, to plan your operations, to think about how you might want to change things, and then really to sort of monitor your performance and make sure that if you're trying to improve that you're actually meeting some goals. Again, before getting into the data, I want to say that we are working in a more and more complex environment in healthcare. And I think that it's just time for us to really start using data in ways that we have not used it before. I think we all have probably done some work with simulation modeling, with optimization modeling, with sort of detailed statistical analysis, and I think those are the tools that we need to use. We also need to recognize the fact that we are working in an environment, we are the perfect queuing model in the emergency department because we have a set of fixed resources and we have unplanned demand trying to access those resources. And so what the queuing model will tell us is that we can operate pretty well up until a point where we reach a tipping point where the incoming demand exceeds reasonably our expectations to meet that demand. And then what happens, and every one of you who's worked in an emergency department has felt it, when you hit your tipping point and your utilization goes beyond a reasonable expectation, it's not a subtle change, is it? Right? When you hit and pass your utilization point, that's your tipping point for your own emergency department, things go badly quickly. Suddenly your waiting room is full and patients wait for very long periods of time. So you can see the shape of the curve after you hit a tipping point in a typical queuing model is not subtle. Yeah? And so this is the kind of thinking, though, that we need to now employ. We need to start thinking about utilization rates and how we manage that. And how we manage it, frankly, is to keep three things in balance. If you have the right number of patients and the right number of beds for the right amount of time, life is good. But let one of those three things get out of sync with another, and it's going to be a rough day. And so that's the kind of data that we talk about here when we talk about operational benchmarks. So in terms of the data set, in terms of, remember now we're focusing on academic emergency departments, we have information from about 100 emergency departments across the country. And they're pretty active emergency departments. You can see that we're distributed pretty well around the country. And the data that we have represents over 6.5 million emergency department visits, about $750 million of collected revenue. And of course, we in the academic world have to be concerned about our research function, and that was reported earlier today. So if you took a snapshot, just a single snapshot, and many of you know this, but for those of you who don't, the people who participate in this survey can get very, very specific data. The data I'm sharing with you right now today, and all of us will share with you, is aggregate data. So here's a picture of the academic emergency department. The academic emergency department has about 54 emergency department beds, and it operates in a hospital of about 600 beds. It sees something around 69,000 patients, about 26% of which will be hospitalized. And in our definition, hospitalized means you go into an inpatient setting or you go into a status of inpatient observation. That does not include ED observation. Those patients are still discharged. In terms of length of stay, patients spend somewhere in the vicinity of 4 or 5 hours in total length of stay. More if you're admitted, less if you're discharged, by and large. And you typically hear community hospitals having a left without being seen rate of something less than 3%. But in the academic environment, you see that it's crept over 3% this year. We also take care of certain specific patient populations, and what this data here would suggest is that you probably ought to pay attention to your EMS population because a disproportionate percentage of those patients end up being admitted. So about 26% of our patient population in the emergency department arrives by ambulance, and about 40% of those patients are admitted as inpatients after their visit in the ED. Now, that varies tremendously from place to place. In my setting, for example, at Hopkins, people tend to use EMS a little bit more as a taxi, so our admission rate of EMS is only about 30%, as opposed to the national average of 43%. But you should understand that, because it really does sort of affect the fact that, you know, when you talk about your admission rate in your emergency department, you talk about 26 or 27% of your patients being admitted, it sort of ignores the fact that if EMS really does have a 45% admit rate, your walk-in population is at relatively low risk for admission when all is said and done. And so I don't know how that exactly changed your mindset, but it's an interesting number. This is an interesting number for me. The behavioral health patients are a relatively small percentage of our population, but you and I both know they use a disproportionate share of bed hours because of their length of stay. And so it's important to keep an eye on both the behavioral health patients and, frankly, the patients greater than 65 years old. I don't know whether or not we're going to see, Kathy's going to talk a little bit about volume trends, and we're going to keep an eye on this patient population because clearly their population is aging. But it's been interesting that over the last couple of years anyway, it doesn't really appear that we're seeing a greater percentage of elderly patients. And so we're going to have to see what happens as we continue to age. And just go back 1 second to point out that if you operate a separate pediatric emergency department, the average pediatric emergency department sees about 25,000 patients per year. Now, Kathy's going to talk about trending, and I am not, so the only thing I want to point out here is first of all, that our current, the current total volume of patients is about 70,000 on average, with about 50,000 or so being admitted. About 17,000 being admitted and about 50,000 or so being discharged. Now, without talking too much about trending, it does look like there might be this slight uptick in volume. In terms of length of stay at the median, we can't say that there's been an incredible change in the length of stay. Maybe a little uptick in how long patients spend in the ED if they are admitted. Now, the only reason I'm showing you this is to get back to my soapbox of the three things that impact throughput and impact operations. Because if, in fact, we have seen a volume increase, and if length of stay has stayed the same or maybe ticked up a little bit, then what we see there is an increased demand for bed hours, right? More patients coming into the same number of beds, assuming we didn't increase bed capacity. And according to our data across the country, we did not increase bed capacity in the emergency department. So volume goes up, length of stay stays the same or ticks up, beds haven't changed. We now have an increased demand for bed hours and an increased bed hour utilization. So we have effectively taken this line and shoved it to the right, which means we're in dangerous territory here of essentially being always overcrowded, always having patients waiting. And so you would say, well, that's probably then perhaps led to some reduced operational performance. And again, we haven't looked at this statistically, but if you look at the left without being seen rate over the last few years, it has ticked up. So I would argue that our increased demand and our increased bed hour utilization is in fact affecting performance. We spend a lot of time talking about how sick our patients are, and we talk a lot about whether or not patients that we see in the academic setting are different than patients seen in the community. And it does appear that there is a difference when you look at ESI distribution between the academic institutions and the community. We see more level 1 and 2 patients and less 4 and 5 patients than they do in the community. Some of that may be driven by the presence of pediatrics in the community hospitals as opposed to the academic institutions, which tend to have separate pediatric emergency departments. So the presence or absence of kids makes a big difference in your triage acuity. I don't believe ESI is the best way to look at acuity. I don't think we have a good way to look at ultimate acuity, but it's what we have right now. As far as kids are concerned, if the take-home message from this slide is if you are managing a PEDS ED or if you're planning a PEDS ED, please don't use adult ED data to do it. Because the pediatric population, we all know that children are not little adults and pediatric EDs are not little EDs. They're just different, and they're different in every way, and you should pay attention to that as you think about pediatrics. Length of stay is clearly something that we're all interested in for our patients, right? It's what drives patient satisfaction, it's what drives bed utilization, and so we're always interested in what are the factors that can affect length of stay. Last year we did some digging around at the admitted length of stay, and very clearly that was driven by how much time patients spend boarding. Well, the interesting thing is that when you look at the length of stay for discharge patients, boarding is still the biggest, the single largest variable in determining how long your discharge patients will be in your emergency department. Lots of data behind this, and there are other things that have some impact on discharge boarding, on discharge patients, but boarding continues to be a big issue. We started asking questions differently. When you think about staffing the emergency department, any of you who've had to come up with sort of the how many people do you need to staff my ED, we always tend to fall back on patients per hour as a metric. I've never liked that as a metric for anything, but it also doesn't really get to what we're referring to as the cognitive load. How many patients can an attending physician reasonably take care of at one time? How many residents can an emergency physician realistically have working with them at one time? And so we just started to ask a question, and I don't know whether this is the right way to ask the question, but it was fascinating in its results. So we said, on a typical Monday, we all know what that means, right? Monday afternoon, 3 o'clock, in your main emergency department, paint us a picture. How many people are there? How many patients are there? How many attendings are there? How many residents are there? And so forth. And we got some very consistent and very interesting results that basically come down to the attending physician ends up being responsible for about 17 patients. They have about 2 providers working with them, either a PA or NP or a resident, and each of them is responsible for somewhere in the ballpark of 7 patients or so. And so this is just sort of the initial look at what this cognitive load question looks like. We've used it already. As I was making a case with our institutional leadership about a staffing plan that we wanted to put in place, I was able to show them that it was consistent with what we consider a reasonable national standard to be. Another new question that we asked this year had to do with ultrasound, which of course is a growing tool for us to use in emergency medicine. We asked a number of questions. Essentially everybody uses ultrasound. Less than half of us, though, bill for that service on the hospital technical side. Almost all of us bill on the professional fee side. However, when you look at the collections, it's pretty pitiful. You will not getting rich on ultrasound. Collection rate is about 20%. I think insurance companies are still typically not paying for it. But we all do pretty much all of the same examinations with ultrasound technology. So that's pretty much it for the introduction to the data. We're going to have time for questions afterwards, we hope. And so Kathy Harbertson is going to talk now about the trend of data over the last 5 years or so.
All right, good morning. I need the clicker, thank you. So some of the slides are going to be similar to what Jim presented, but hopefully we'll have some numbers with them this time. The data set that we're looking at is FY12 through FY17. So that's the same as academic year. It just depends if you're in finance or academics. Reason we just chose these 6 years is around FY12 is when I started working on the data, honestly. And also our question set kind of stabilized. So we have most of these metrics. We also, by that time, it was about 5 years into the survey, and people were getting better at reporting real values. I'm looking at medians. And then you also see, we do have a little bit of maybe a confounder in here that in the last 2 years, our responses have greatly increased. And so these are sites that may not have participated in those first 4 years. People also do come in and out as their administration changes. The survey is over 300 questions, so sometimes people don't get to it. All right, patient volume trends. What we're really seeing is we're increasing at about a rate of 2.5% every year. And disproportionately, that number is hospitalizations. So in theory, that means we're seeing a little bit sicker patients. We'll get more to that in a second. Regionally, pretty much, back. It's a little bit all over the place, but in general, we're seeing a trend up in every region, not just in certain areas of the country. Okay, acuity. Who are these patients? Are we seeing the same types, or are we getting sicker and sicker patients? And pretty much across the board, we're getting sicker patients. Hospitalization rates are up. High acuity prophies, which could be tied to billing, but also because we have this acuity and these EMS arrivals and EMS admissions also increasing. with all these 5 metrics, I would argue to say that you're seeing sicker patients than you used to see, which, yeah, you're seeing more patients, they're sicker, it's adding to that stress on your department. Left without being seen, this one goes all the way back to 2008, but as Jim mentioned, it makes it look like we were doing better, but in the most recent period, we're seeing that the uptick back to where we were about 6 years ago. Length of stay. I would say there's pretty much no change. Is that good? Is that bad? A lot of things in your department, I'm sure you're used to it, are we driving, let's try to reduce length of stay over and over again. But if we're seeing sicker patients, we're seeing more of them, maybe this is a good thing. You know, length of stay isn't increasing even though we're having this higher load and this higher acuity. Boarding, you know, it's kind of steady. It went down. This last year, as we can see, it's increased again, so we need to keep an eye on that. Have we finally reached that tipping point that Jim talked about? Finally, so those numbers had all the data, people coming in, coming out, whether or not they responded. We asked our analytic partner, Roundtable Analytics, to do a model for us so we could see people that participated multiple years in a row and use them to trend to make sure that we were seeing the right things. And so what we did is look at a typical ED that has 65,000 visits. And what we saw is it's actually a little more pronounced than what the other data showed. And then we also look here at what that translates to in number of patients. So you're seeing 1,700 more patients every year than the year before. About half are hospitalized and half are discharged. You're seeing 620 more EMS arrivals, 400 more about 400 more of those are admitted, and then an increase of 400 critically ill patients. So it's a high stress. Regions, where's the growth? The Northeast and the South are the highest growth. But when you actually look at it in terms of new patients, the South has much smaller EDs because just their population is smaller. So you're seeing more patients coming in the Northeast and the Midwest. And finally, we cohorted data. I don't know if any of you are familiar with the ED Benchmarking Alliance. It's a very large benchmarking survey, but it encompasses community sites, not just academics. And they do this cohorting where they look at ED volumes, and so they do buckets of 20,000 visit levels. And so as we can see from when we bucket these EDs into their annual volume, that the small EDs are the ones that are seeing the most growth. But in the end, it translates to roughly about the same number of patients. It's just because they started at a smaller level. And that's it.
All right, I am going to talk about quality and throughput. So here's some basic quality metrics. I'll leave you read through these. Basically, comparing them to last year, the metrics stayed pretty consistent. And as has been mentioned, the one that did go up is the boarding time. So we'll have a little bit more information on this as I go through the slides here. So quality measures, septic shock. This was a new one, CMS measurement this year. We decided to try to collect it within our group. And out of the nearly 100 respondents, we had about a third who could actually turn in some data. The reason is the definition is kind of hard and it's difficult to pull the data, so there's still a lot going on about this. The other issue is we do have these percentages, but we don't know what they mean, if they're good, if they're bad, exactly what's going on. So first year with this, we'll see where this goes. Some more sub-cycle time data again. These are very consistent with previous years. All these numbers are almost in line. Whoop, wrong button. These numbers are very much in line with previous years. The one exception here is door to provider. So if you can see going back to FY12, we were at a median value of 38 minutes, and then it dropped down to 35, and then it stayed pretty consistent at 30 the last 3 years. And then in FY17, for some reason, we dropped down to 26 minutes. One thing we're thinking is maybe now that's the triage provider, arrival zone type provider. About 55% reported having that, and of those group, the number was 25. So there's really not a big difference between the 25 and 26. So we'll have to keep an eye on this, and hopefully we can keep that number down. So boarding time, a lot of talk about boarding time. For our survey, we define boarding time as the moment the admit order goes in till the minute the patient leaves the department, okay? So this first set of data here are patients that are in the department under 4 hours, 4 to 8, and then greater than 8. So depending upon if your glass is half empty or half full person, 70% of our patients are only in there 4 hours or less. But that number's decreasing. Since 2012, it's gone down 7.5%. The number staying 4 to 8 hours has increased 13.7, and obviously the big one is greater than 8 hours has gone up 70%. So I think everybody's feeling that pain throughout the country. So a little bit about OBS. 34% of the respondents report that they do place patients in an ED-OBS status. 29% actually report having ED-OBS beds in their department, and of those, 49% have dedicated hours for OBS. As far as the data goes, again, the arrival to order actually went down, so we're getting them in OBS quicker from the previous year, but when they're there, they're staying longer. So here's some more OBS data. I won't read through each line, but basically just showing the use is going up, volumes are going up. The interesting one is the very last number here, 34.4%, or 34.3% is showing the percentage of our patients that come in and are not discharged. They either need admitted or some type of OBS status. So patients are getting sicker that we're treating, obviously. Ancillary resource utilization, again, very flat. Not much difference over the last 3 years. CT turnaround's about the only one that's really improved. So patient satisfaction. So we as a group, we're reporting Press-Ganey scores the first few years of the survey. The reason we picked Press-Ganey scores, it was the most popular one amongst the group. So we collected the scores, and Jim is very much adamant about every year when we meet, if we're going to add questions, we have to take questions out. So FY13, after that year, we decided to pull out the Press-Ganey scores because Press-Ganey had their own benchmarks, so why are we worrying about collecting it? So we pulled them out. So for 2 years, we didn't collect Press-Ganey scores. And I was back at Ohio State talking to our vice chair of clinical affairs, talking about our patient satisfaction scores and how we're in the teens of the percentiles. And I was when I worked up at Case Western up in Cleveland before I went to Ohio State, we were down in the teens. And when you talk to our peers, everybody's like, yeah, we're in the teens, we're in the 20s. You know, no one, you ever talk to somebody who said we're the 90th percentile, right? So we decided to, well, why don't we take the Press-Ganey scores we collected from AAAM survey from 13 and compare that to the Press-Ganey survey scores, the percentile benchmarks. So when we did that, the data looked different. So I went back to the benchmark committee in FY16 and said, hey, look at this data, it looks different. Let's collect it, see if that was an anomaly, if it'll repeat. So I looked at 16's data. Sure enough, the data was different. And we did it again last year in 17. So I'm going to show you 17's data here. So again, the way we did this, you just had the percentile rank, and then what the raw score was to correlate that for AAAM, and for what Press-Ganey used to call it the UHC, their academic benchmark group, and then just their large hospital database group. So we just lined up these scores and did a statistical analysis of that. So for the MD roll-up scores, here's the box plot. So as you can see, these two are the Press-Ganey scores, and this is AAAM. So they don't look very much alike. Statistically, it did come out showing that they were significantly different, the AAAM benchmark compared to the Press-Ganey benchmarks. So graphically, this is what it looks like. Again, the red line, that's the AAAM, and here's the two Press-Ganey benchmarks. So if you look, percentile ranks down here and what the raw score would be, the two Press-Ganey benchmarks don't look any different. What they call academic doesn't look much different from their large hospital. So what this translates to is, if you have a score of 82, for AAAM, you'd be the 50th percentile. If you use what Press-Ganey calls their academic, you're then the 18th percentile. And for large hospital, you're the 12th. So why this is important, obviously, if the C-suite says, I have academic benchmarks from Press-Ganey, you're at the 18th percentile. Well, academic benchmark for AAAM, you're actually the 50th percentile. So it's much a different look. So basically, the Press-Ganey cohort includes a lot of other, probably smaller community hospitals that consider themselves academic versus the AAAM, which is pretty much all the big academic institutions. So we did the same thing for likelihood to recommend the ED, and again, you can see the box plot. AAAM looks much different than the two Press-Ganey ones. Statistically, same thing, even had a larger effect size. And again, graphically looking at the same thing. 50th percentile, score of 77 for AAAM, puts you at the 22nd or the 11th. So again, much different picture depending on how the C-suite looks at this. So bottom line is different methods to aggregate are going to give you different benchmarks. At any given percentile, the Press-Ganey score is going to be higher than a AAAM score. They are statistically different, so this is shows that you really need to watch what you're comparing yourself to make sure you have the correct comparison. So this showed this way for the Press-Ganey scores and patient stat, but obviously all these metrics we're collecting, like Kathy said, there's EDBA out there, which is a totally different cohort of groups. So you just got to be aware of who you're comparing yourself to, and is that really the most accurate or the comparison you want to be doing. And with that, Dr. Volturo.
Thank you. Okay, you've now heard volume's gone up, acuity's gone up, Press-Ganey scores have gone up. That's a good thing. So let's get to the depressing part of this talk. Okay, volume's gone up from 2012. However, our hours of provider coverage in the main ED have not gone up since 2012. It's exactly the same, 186 hours a day, 2012, 106 hours a day, 86 hours a day in 2017. How have we responded? Well, resident work hours are, wrong button. Resident work hours are decreasing so that we've gone from 55% of the ED coverage with residents, work hours with residents, down to 52%. Pretty much have held stable, although we have reduced the APP coverage a bit in the ED. What we have done is responded to this by increasing attending physician coverage in the ED, on average of about 10 hours a day over the past 5 years, right? So our attendings are working more in the main ED, and I suspect in most places independently. When you look at annual faculty hours, 2016 to 2017, you could see that we've made a big jump in hours, about 3,000 hours, a little less than 3,000 hours, and we're doing that with one less faculty member. Okay, so our attendings are working more hours. If you do this, and keep in mind that this encompasses what may be part-time faculty in there also. So, but if you look at the aggregate, it was 832 hours per faculty member in 2016. It's 948 in 2017. So the trend is to increase faculty work hours in addition to increasing the number of faculty. Yes? These are just clinical work hours. Clinical work hours. Okay, so you could see over the past 5 years, there's been a general trend of increasing the total number of hours we're putting into the ED, and that's how we've responded to the changing acuity and changing volume. Where the biggest impact has been is really roughly about a mean increase of a little over 2,000 hours. But the biggest impact is really in those EDs from 60,000 on up, where the hours have been added. EDs under 60,000 really haven't seen as much of an hour increase. It's primarily been about 1,100 hours in the EDs less than 60,000. Now, this is a very interesting graph, and as I explain it to you, depending where your ED sits, you may either want to love this graph and take it and show it to your CEO, or disavow any knowledge of that it even exists. But this is a scatter plot of EDs that look at your annual physician hours versus your total volume. And then you can see in this, the initial bag graph here, right here in the center bag, that represents about 50% of the EDs, okay? So you could see it's a pretty linear relationship as volume goes up, and we're pretty consistent and close, okay? Now, if you're sitting down here, I could tell you that I'm sitting right down in here somewhere. But if you're sitting down on this side, you can use this to justify that you're understaffed for your volume. But if you're sitting over here with 60,000 hours for roughly 90,000 visits, don't ever show that to your CEO. Because you can see exactly where the medians are with this bag graph. So, and for this data is available to the members of AACEM and AAAEM, and they can actually go in and see where they sit, and hopefully use this very effectively. So, on whole, you could see for every patient that increase in patients, we had about 23 minutes of time. Every 4,000 patients come up to about 1 FTE. Roughly every 20,000 patients, you're looking at adding about 7,800 hours. If we look at who's really working, you could see that most of the hours put into the ED actually are physician hours on any given day. It does increase, as one would suspect, as the volume increases. We have more physician hours, we have more APP hours, and we have more resident coverage. But it sort of stops right around that level, okay, that the residents don't keep going up because there's not an excess number of residents. When we get into looking on how things are changing, you could see that clearly in these 60,000 and above, we've added additional anywhere from 7 to 13 hours a day of physician coverage in this group. And really interestingly, what has happened across the board is that we've decreased physician time in fast track. Anywhere from 3 to 25 hours a day have been taken out of fast track, physicians taken out of fast track. So, and that is consistent. I think we're seeing sicker patients, and fast track has a little less utility in many of our EDs. Now, in terms of productivity, you can see here the median and mean RVU production. These are numbers I really do want you to keep in mind because these are going to come up again. If this relates into patients per hour, about 2.33 to 2.25, 5 patients per hour are seeing. And our collection for RVU is about $45, which is up about $1.50 since from the year prior. So totally, if you just do the math based on what is defined as clinical FTE, one would expect a production between 10 and 11,000 RVUs if somebody's working full-time clinical in an academic affiliated ED. This is very different than if you're in a community ED. If you're in a community ED, the RVUs come down to about 6,700 in that setting. In terms of patients per hour, and this is also an interesting change. We keep talking about this 2 patients per hour. Last year, what we were seeing is this climb, and that these higher EDs were getting up to close to 3 patients per hour. And you see they've come right back down. Why? Because we've added, those EDs have all added hours. So this 2 patients per hour does seem to be probably a real kind of metric that ED physicians are comfortable with. When we're getting above that, I suspect it's making us uncomfortable. Now, keep in mind that this is over a 24-hour period. And so it doesn't take into surges, it doesn't take into account the fact that at nighttime it's very, very slow. And this is just an average, right? Now, when you add productivity, this is just to demonstrate that when you start to add the APPs in, again, it ultimately decreases the patients per hour that are necessary by the providers that are being seen, so that the combined hours come down to about 1.3, 1.4 patients per hour. We're going to come back to patients per hour, but just a reminder, in an academic setting, we have many missions, okay? And roughly about 70% of our mission ends up being clinical. That's where the money comes from, and that's what drives everything else. Roughly 13% is academic, 6% research, 10% devoted to administration. And that's pretty standard, and that is across all of our contributors to the organization. Now I want to come back to this concept of cognitive load. So we took a census Monday, 3 p.m. Everybody's relaxing, having coffee Monday, 3 p.m., right? All our EDs, we looked at the average ED, and roughly the average ED has 41 acute beds in it, and we had 56 patients in there at 3 o'clock in the afternoon, 137% capacity. So now when you break this down and you start to look at our census of 56, and you're getting down to attending load of 15 to 17 patients with 2 providers, how many folks at 3 o'clock on a Monday afternoon are only dealing with 15 patients in an academic ED? Okay, I would tell you, and I know some of my attendings in this room that work for me, in our ED at 3 o'clock on a Monday afternoon, the attending is probably carrying between 30 and 40 patients. That is way past what the cognitive load is. And if you look at how EDs, I've been doing this a long time, how EDs have been designed over the years, we rarely would design a single ED with more than 17 or 18 beds and expect single coverage with it, right? Because we always based it on 2 patients per hour. So and what's happened is that boarding has gone up. These patients are sitting in our ED, you're still caring for them, they're still part of your cognitive load. So we have to look at this from a different aspect. Now, we can't look just at patients per hour. We have to start looking how many patients you're responsible for, how many patients do you have in your mind. And this is one of the areas that we are going to start looking in more detail as the survey, as we go to the survey this coming year, because I think this is going to have much more impact in trying to decide how we have to staff our EDs with our new patients that are staying there for hours. Because I could tell you in our ED, very much I am running an inpatient unit, an ICU, and an emergency department at the same time. Okay, it's just the nature of the beast. When we have, 6 or 7 ICU boarders, 30 ED general medicine boarders, and then our regular ED load. So we have to look at this for the physicians from a different perspective. Now, everybody wants scribes, right? So we decided to look at scribes, and so we had 90 emergency departments that reported data. 47 of them did not have scribes. 43 did have scribes. And so we looked at a couple of things about scribes. And you're going to have to take this with a grain of salt, too. It's another area that we're going to have to do a deep dive in the next year. But when you look at this, length of stay, if you have scribes, was up a little higher. I didn't relate any reason why. That sort of surprised me. I wouldn't expect it. Length of stay for discharge patients was about 8 minutes less. That I kind of would expect, right? I don't have to sit there and write. They can write the discharge instructions and so forth. RVUs per hour were a little less when you had a scribe. Okay, well, I would think, I was a little surprised by that because I would think the scribes document better and I'd probably generate more RVUs per hour. And that sort of does pan out when I look at the RVUs per bill. Because if the charts the scribes wrote generated a little bit more in terms of RVUs. Now we're going back, we're going to switch from RVUs into patients per hour and dollars. So when you look at these specific hospitals in the no and in the yes category, you could see that the ones without scribes are generating about 2.4 RVUs, 2.4 patients per hour, and about 2.25 patients per hour if they use scribes. Okay, so they're seeing fewer patients if they're using scribes. Now, if you look at the revenue, net per patient, as we expect with a scribe, they're doing better documentation. They get about $3 more per chart if a scribe writes that chart per patient. And revenue per hour, that turns into roughly $3.13 because now we're looking at the revenue times the number of patients. And if you start to look at the end of the day, if you don't use a scribe, you actually generate more revenue, about $113 or so at the end of the day. Now, what this doesn't account for, again, this is not something you want to show anyone in the C-suite, right? Because this doesn't account for the other benefits of a scribe. And I think all of us would probably agree that there's a significant physician wellness benefit by having a scribe and not having to go home at the end of the day, get a beer and spend 4 hours documenting your charts for the day, and you know they're not going to be as good as they were, particularly after the second and third beer. So more to come on scribes. We have more of a deep dive in there. We have to figure out our residents using scribes, what percentage of shifts have scribe coverage, and also more detail to come on that. So bottom line is this database is a very strong set of academic data. It is focused totally on the types of practices that we live in. And it does relate to other databases, and so certainly we've been working with EDMPA also at that. We have a lot of deep dives to do. The database has over 300 questions it takes through. If anyone is an administrator and has to fill out the database, there's quite a bit of work that goes into it. We're working with analytics, Roundtable Analytics, which is giving us the ability to really look at the data and make some statistical analysis that's valid with it. And so this, I think, is going, not I think, this, I know, is the real benchmark that we have to follow. And it's the one that I try to blow away. I use this actually to blow away MGMA and AAMC all the time, particularly when you start getting into salary surveys and so forth, because we have much more robust data in this set. So, questions?
Questions, please. And I think that they're recording the session, so if you can wait to get a microphone, I'll have one. Thank you.
Ron Perello from the Greenville Health System. Is part of this survey including measuring the GME effect of the productivity? Is there a separate section when we talk about how we have conversations with our DIOs and wanting to expand an emergency department or emergency medicine residency? What is the effect of adding a resident? Is this part of your data collection or focus?
So we collect some information about the size of residency programs and whether or not they've changed. The bottom line is it doesn't appear that many residency programs have expanded over the last several years. What does appear is that from the clinical perspective is that as resident hours have gone down, we've replaced them with APPs. And so to that extent, that's the information that we have.
So as we expand in more hospitals, we have there's the discussion of having access to the CMS dollars for a Virgin hospital, putting a resident there, and it all says, well, what does that look like, putting the resident there?
You know, if you're asking about resident productivity, essentially what you're asking is that we have found in previous surveys that residents before their third year are counterproductive. In their third and fourth year, if you have a 4-year programs, they are about as productive as a PA.
Thank you.
Correct. That's it. Well, thank you very much for your time and attention. Enjoy the rest of the conference.